with Dr. Sierra Windsor talking about MCAS and all the ways in which we look for symptoms and diagnosis and lab testing and treatment. This time what we're going to talk about today is in relationship to what types of ways we assess for MCAS, what type of labs we're running, what we consider in terms of diagnostic criteria, what we'll do in a separate video, but what the limitations are and benefits to doing certain types of testing for MCAS. Sound great?
Sounds great.
Welcome back, Dr. Windsor. It's good to see you. All right, so tell us, why is MCAS so difficult to diagnose?
It's a great question. It is very hard to diagnose, and most of that is pertaining to the timing of getting a positive test. Like, you have to have a baseline, and then you have to have testing done during a flare of symptoms. And why this is so hard to catch, essentially, is that all of these inflammatory mediators that we want to measure are like super quick. Meaning, like, they happen, they cause everything to inflame super high, and then they should be degraded down or detoxed pretty quickly.
Like, how fast does histamine in and of itself get produced and break down? In what period of time?
Immediately.
Like minutes?
Yeah.
All right.
So histamine, you would think would be the best marker to check for MCAS. It's actually like the least reliable one because it's just so quick. There's not, like, if you get an elevated histamine, you're like, that's interesting, but it doesn't technically support an MCAS diagnosis.
And this is like histamine in the blood. Like, if you were to check someone's blood for histamine, not super helpful because it's constantly fluctuating up and down.
Exactly, which is why we tend to look for breakdown markers of histamine, like in the urine, because those tend to hang around a little bit longer, so you have a better chance of catching those.
Oh, it's interesting. And then, so how long do those last for? Like, is that like a couple hours, or is that also still kind of in the minutes range?
It's not. I wish it was a couple hours. I usually tell people, like, if we can get the labs done within 20 to 30 minutes of, like, you flaring, that would be ideal in terms of, like, trying to get a positive.
Okay.
So still pretty quick.
So timing is really challenging, and the markers with which we're measuring, they flare up and they break down incredibly fast, so it's hard to get that done on time. Okay, great. So, like, what are some of the core labs and tests that you would run if you do expect someone to have MCAS?
Tryptase is probably the most commonly talked about one because it's the most, like, specific, most slam dunk for MCAS. Meaning, like, if you have an elevated tryptase, we're like, yes, we can use the diagnostic codes. All your other providers have to believe you have MCAS because you have a positive tryptase. But unfortunately, that means a lot of other providers also will not treat or acknowledge that you might have MCAS if you don't have a positive tryptase.
And what are the challenges to getting a positive tryptase? Because I know a lot of people with MCAS can measure their tryptase and it can be completely normal.
Yeah, it's the traditional criteria is like having a normal baseline tryptase and then having it be a certain amount of times elevated beyond the baseline during a flare. So it's really more so like, can you go get a blood draw done 20 to 30 minutes within having a flare?
Or do you have to sit and wait in a LabCorp waiting room while you're flaring?
I have had patients trigger flares in order to then do the testing, but also, like, I don't always recommend that for obvious reasons.
Yeah, I mean, I'm making people feel crappy is generally not preferred.
Just to get a positive. Yeah.
All right, and then is tryptase broken down as fast as histamine, or does it last a little bit longer?
Tryptase is a bit different because it's actually a marker of the mast cell degranulation, which is why it's the best marker. So in terms of, like, if you're taking antihistamines, that won't affect the tryptase because those are just blocking receptors.
Got it.
So it doesn't have quite the same quickness to it that some of the other, like, histamine breakdown markers do, but we still try and want to get it in that, like, 30-minute time frame.
Yeah, 30 minutes is really fast. It's like, because how are you supposed to go get your blood drawn within that 30-minute marker?
Yeah, run to LabCorp.
Oh my God, assuming that you have a place you can go.
Or it's the middle of the night and, like, what are you supposed to do?
Yeah, you can't do anything. What are there other markers that might be indicative, maybe like prostaglandins or heparin or something like that?
Yeah, I usually check prostaglandin D2, which is a blood test. And then there's a couple urinary markers, and sometimes those are a nice option because if you do have a flare in the middle of the night, like, I'll have patients have a urine cup on their nightstand just in case we can try and catch it quickly. But even then they have to be processed in a certain way, and not all labs do that, so it is complicated.
So then if someone is having a flare, you can give them a urine cup, they can pee into a cup, and then, but does that cup of urine have to be processed in a certain amount of time before the prostaglandins break down?
Yes, it probably would need to get to LabCorp, like, right away.
Like within a couple hours?
It's a good question. I'm not sure. Yeah. I think I've had patients freeze it and bring it in the next day, and I think that it was fine. But it does have to be like frozen pretty quickly so that everything doesn't break down.
So if they do like do it in the middle of the night or on a weekend when they can't get into lab, good idea to just freeze the sample and then take it into LabCorp the next day. Okay. And that still has to be processed a special way though, so they have to make sure they're getting the right testing done.
Yes, yeah, they normally have to send it out to a different lab to do that.
Okay.
Yeah.
And you said histamine's not a super reliable marker in the blood because it's like flaring up and breaking down. Are there other markers that might tell us a little bit of something?
So we check for the N-methylhistamine, which is a breakdown marker of histamine, and that's in the urine. So that one lingers a little bit longer. So that's one. And then we also look for urinary leukotriene E4 is one as well. Okay. There is a serum test for leukotriene, which is another inflammatory mediator that can be used in diagnosis, but I haven't found that LabCorp Quest does that marker, so they only do the urinary ones. Are there
other tests that might, or are there other labs that might be able to run those types of tests that are not like major labs, or is it just like those are kind of the best places to get them done?
I usually recommend doing through LabCorp Quest for like convenience. I haven't looked into if there's like a functional other like blood test. If there's not, I think it'd be a fascinating idea for someone to have like an MCAS panel.
Yeah. Okay. And then if so you talked a little bit about timing in terms of making sure that like people can collect samples or get their blood drawn when they're having active flares. But assuming that they're not having an active flare, do you just get no testing at all? Do you just wait until another flare occurs? I mean, sometimes you said you trigger them, but what do you do in that particular case?
It's a good question. I usually will offer these tests as like establishing a baseline, and sometimes surprisingly you still do get positives. Some of these inflammatory or mediators or markers will have other things that could also cause them to be high. So if anything, it does kind of prompt us to look at other conditions that might be playing a role besides MCAS. And some patients I have the discussion with them like, hey, it sounds like you have MCAS, the history's all lining up, the symptoms are all lining up, you respond really well to antihistamines. We can certainly try and get the testing done, but I think sometimes it doesn't feel very validating to patients who are like, we know this is going on, and then not getting the positive test. So some patients, I'm like, if the diagnosis and that number is really important to you, then yes, we should try and get it. But is it going to change how we treat you? Potentially not.
Probably not.
Yeah.
What percentage of people do you feel like who have MCAS actually test normal on labs? Have normal?
Almost all of them.
Almost all, like more than 90%?
Like at least 90.
Yeah.
When you get a positive, you're like really excited, almost because you're like, it doesn't happen very often.
Yeah. So that's like a huge percentage of the population. So a majority of people will have symptoms of MCAS. You're pretty positive it's going to be MCAS, but you're not going to get that confirmation on labs that you necessarily would.
Yeah.
But it doesn't. What you're saying is that it doesn't always matter because it's not really going to change what how you're treating it anyway.
Yeah. At least in our world, I think in terms of like an allergist or an immunologist or these other specialists, like I've heard patients not get treatment because they don't meet the pure diagnostic criteria with like a tryptase that's positive. So that's kind of am more confident in being like, okay, you match the clinical picture. Let's see what happens if we give you these treatments, and usually people feel a lot better.
Yeah. Is there a set diagnostic criteria for MCAS?
There is, in terms of it's really just about correlating the symptoms to the lab markers and having those positives, like during symptoms together.
And the diagnostic criteria requires that you have the positive lab markers? It doesn't just say, well, it's nice to have them, but symptom correlation can also...
It does require them, and that's what's tricky. You have to have symptoms in multiple body systems, which we kind of talked about last time, and you have to have the positive lab, and then you also have to have a positive response to an antihistamine.
God, that's going to be really frustrating because if like greater than 90% of people might have normal labs, even though they're having MCAS flares, then it would be really frustrating, I think, for a lot of people who can't get that official diagnosis because of that particular criteria.
And I'm really looking forward to them potentially changing or modifying that criteria. Kind of what they just did with endometriosis, right? They're like, oh, you don't even need exploratory surgery anymore because who the hell is going to get exploratory surgery? Who's going to trigger an MCAS flare just to meet the criteria?
Yeah, to do that. And I've seen patients do this where they go into allergists too. They require that they have that flare so they can get that positive lab marker, and that just is not pleasant for a lot of people, especially if they're already responding well to antihistamines.
Yeah.
Yeah, I'd be curious to see like even if part of the diagnostic criteria looks at positive response to antihistamines too.
Mm-hmm.
So, yeah, that's really interesting. Okay. Well, I think that was super helpful. And then I want to talk a little bit more about the diagnostic criteria and in terms of differential diagnosis and other types of conditions you think about. So we'll make another video about that. And then we will work on a video about kind of what our treatment options are and what things people have available to them.
Awesome.
Great.